let's begin. It gives me great pleasure to introduce. Gives me great pleasure to introduce Professor Paget. He's the head of the Division of Nephrology, and he's going to be talking about a really important topic of malignancies and renal transplantation. We're seeing an increasing number of malignancies in the general population. He's going to talk about how this impacts your ability to access dialysis and transplantation. He's going to talk about renal transplantation increasing the risk of malignancies and what does it mean for treatment. And we look forward to his entertaining talk. Thank you.
Right. Morning. Good morning, all. As you know, I'm a very serious speaker always. Thank you for coming. At least I've got someone to talk to. So, thank you very much. So we're going to talk a little bit about aspects of malignancy. I've tried to sort of make it a bit more general. The first problem is... I can do it that way. Okay, so I thought an illustrative case just to show kind of how difficult it can be and what happens to us when we manage renal patients. So this gentleman I've known since 2011. He was 38 back then. He's from Cameroon. He's fortunate enough to be funded by his bank. And he's a really nice fella. So, of course, he's had a terrible time. Isn't that the way medicine goes? We all know that. So he first came to us as having some complex vascular access issues. He was said to have had membranoproliferative GN as the cause of his end-stage kidney disease. He was hepatitis B positive. He was on antivirals, 3TC and TDF. He'd had really upwards of 50 access surgeries and perm caths, failed grafts. He'd really gone through a lot, both in further up north as well as down here. He had multiple lower limb DVTs. He'd been on warfarin for years. It's hard to monitor the INRs in Cameroon. You'll send the blood off. It'll go off to France. It'll come back in a couple of weeks and tell you it's 8. That's a problem. He managed to survive a craniotomy for a subdural hemorrhage. And after a while, we began discussing whether he should try and be transplanted and how that would work. He, of course, underwent initial workup for a live donor kidney. His wife offered the kidney. And during the course of the investigations, there was a cyst noted in the lower pole of his right kidney. Those not familiar with the Bosniak staging system for renal cysts, essentially the cyst took up contrast. It was not a big cyst, but a decision was taken then to remove that kidney. Histology confirmed that he in fact had a papillary carcinoma, and then this was confined to the kidney with a fairly low nuclear grade score. So we'll talk a little bit about what you do. So we said to him, look, you need to wait approximately 3 years. Just carry on, suffer along, do the best you can. And he underwent CT scanning 3 years later, which showed no problems. So he underwent a live donor transplant for his wife, a very happy occasion. He was seen in February and June, and he seemed to be well. And then he was being monitored back at home. And then I have a lot of WhatsApps with patients all over the place. I got a message on the 1st of October 2023 that he seemed, from what I gathered, that he developed nephrotic syndrome with hypertension and renal dysfunction, which he'd attributed to an episode of malaria and what sounded like dysentery. You must understand how difficult it is how fortunate we are in South Africa, to be honest. He arrives in South Africa on the 15th of October, and he undergoes a kidney biopsy, which unfortunately confirms that he likely has what's called a C3 glomerulopathy with crescents. C3 glomerulopathy implies an abnormality of the complement regulatory proteins, and it's managed by a drug called Solaris. Now, Solaris, for those of you who don't know, is given every 2 weeks, and the cost is $7,500 US per injection. This is the reality. Forever. Right, doesn't stop. So we had a discussion around that. He said, oh my goodness, I don't have you can get a discounted rate in the UK of £330,000 per annum. Just do those numbers as well. So about 6 to 8 million rand a year. Anyway, his GFR is about 15 mils. He's taken a big knock. His urine protein is significantly up. He also has BK virus at low levels, so it's just a warning to be careful. And his hepatitis B viral load is okay. He's treated with plasma exchange. IV endoxand, his Cellcept is stopped, or his MMF, and he's given Solimedrol. He's reviewed in December and on low-dose oral endoxand for, sorry, that should say 1 month, actually, not 12 months, 1 month. In January of that year, his GFR, we get some salvage. It's about 18. His urine protein is still significant. So then he switched back to MMF and low-dose tacrolimus. In November 2024, I get another WhatsApp message saying he's got some funny lumps in his groin and his axilla, which he's had for 3 months. Can he come see me? And now his GFR is about 13 mils when he arrives, and his urine protein is a little better, but not great. And this is the histology that we obtain from his groin, showing HHV8 associated Kaposi sarcoma. That's not great. Okay. So he receives his first chemo in December 2024. As is fairly standard, he's admitted to ICU shortly thereafter with neutropenic sepsis requiring dialysis. And then he actually settles down. He's fortunate enough to have funding for liposomal doxorubicin. It's fairly expensive, with hemodialysis once a week. And so now, what do you do? He says, am I going to lose my kidney, doctor? Is there nothing else we can do? And you say, gee whiz, you know, this is a bit of a tough one. As it turns out, the ancestors decide for us. It is decided he needs a chemotherapy break for a couple of weeks to see if he can go back to Cameroon for a bit. And after 2 weeks, new lesions appear in his right thigh, classic Kaposi sarcoma. Then we have to have a heartbreaking discussion around the fact that his immunosuppression needs to be stopped, and he now needs to be committed to hemodialysis without much vascular access, and essentially probably never be transplanted again. Unfortunately, we'll talk a little bit about it, but rapamycin is actually somewhat contraindicated with low GFR. And just to say, he's currently in the ICU at Donald Gordon, having had an extensive hemorrhage from his Kaposi sarcoma in his thigh on Monday, and he's had some radiation. So this is the kind of thing, the situation that we face. So I wanted to just talk about it a little bit. So cancer is a growing problem. It's a little bit of a wild graph, this, but anyway, there's estimates of about 20 million new cases incidence, 20 million new cases per annum, and about half of those patients, so about 10 million deaths per annum. It's interesting that Africa seems to represent, I'll have to just put my eyeballs in, 7.8%, which is a bit, either Africa's a great place, you don't get cancer, ever. It's really good. But there are 1.54 billion people living in Africa. So I'm not sure, right? So I think in Africa, we're just as affected. So it's something you are going to see more and more of. Why that is? Well, there's lots of theories. So I haven't had the urge to email the authors of this paper and say, why did you put paraneoplastic renal manifestation twice in the little blocky? Were you trying to say something? But what's important to realize about cancer, the kidney, is they're linked. So you may get cancer of your kidney and it has to be removed. Chemotherapeutic agents, lots of the cancers, you require things like cisplatin, immunotherapy, gemcitabine. These drugs are harmful to the kidney, and a lot of patients are then left with CKD, and that's difficult. We know that patients vomit, they need contrast, they take non-steroidals for pain, so there are multiple reasons why patients with cancer will see a nephrologist. I see lots and lots of, we see lots of cancer patients, so it's an important thing for us. And here's the fun part. So cancer is important in whether or not you can access life-saving dialysis in our healthcare system. So on the left, down the bottom, this is the Barbara Hogan document. Down there, you see medical exclusion criteria, active uncontrollable malignancy or with short life expectancy. What exactly does that mean? It's a tough one. And this here, for those of you on medical aid, right, you're all going to be fine. NHI, we're all going to do well. This is the med scheme form the nephrologist has to fill in. You notice these are exclusionary questions that are asked that the doctor must fill in. And there it says, Does the patient have cancer? Provide details of the stage, treatment response, and prognosis. And there are patients who are then refused dialysis because they have a cancer of some sort. So it's important that all of us realize it's not necessarily a death sentence. It's important. You will see more patients with cancer and renal failure, and you need to be aware of these. Right. Just a little thing about the epidemiology. So the standard incidence ratios of malignancies really are linked to 7 oncogenic viruses, which are super clever, to be honest. So what we tend to see is a much higher increase in non-melanoma skin cancer, lip cancer, oropharyngeal, KS, and also, again, oncogenically virally driven cancers like cervical vulvar lymphoma, thyroid to a certain extent. Not so much the solid organ malignancy, somewhat less. Okay, so we don't see as it's not a big thing for us post-renal transplant. We absolutely see patients with colon cancer, so they get normal things as well. All right, so that's important to remember. They're aging people, they're on dialysis, they've got, they've had a bad diet or whatever, and they've got cancer. So the risk factors for cancer are somewhat similar to, well, there are similar risk factors, but for particularly transplant-related cancers, it makes sense that the higher levels of immunosuppression that you use, so we are starting to look at things like ABO and pre-sensitized transplants to try and sort of get somebody a chance to get off dialysis. This is going to have a consequence because particularly when you deplete CD8 cells, when you're on calcineurin inhibitors for a long time, essentially your immune system does not survey for cancer cells. If you have rejections during your transplant, so we are seeing lots of patients spending a lot of time on the wait list, getting transfusions, etc. They get more sensitized, and therefore they have more rejections and they get more immunosuppression. It's also important, remember that mutagenesis in cancer depends somewhat on an injury to the organ. So it's no coincidence that you get liver cancer when you have cirrhosis, You get lung cancer when you smoke. They seem, mutagenesis offers the opportunity for abnormal development of a cancer disease. So it depends on what kidney disease you've had. So patients who've got multicystic kidney disease, so people have taken lots of analgesics or have had urinary tract infections, etc., over years, and with reflux as a cause, they may be predisposed. And then, of course, the viruses. So these are them. There's only 5 listed here anyway. But so the big Epstein-Barr is. Oh, sorry, I didn't mean that. Epstein-Barr is an important one. I like Epstein-Barr. I'm looking at it at the moment. It's a really cool virus. Okay. HHV8, well, is associated. This HPV is a big problem, all right, both for skin and the perineal region. All right, we'll talk a little bit about it. And you're fairly familiar with hepatitis B being important in the pathogenesis of hepatocellular carcinoma. So oncogenic viruses, the sort of 5 or 7 oncogenic viruses, share unique properties. So they're good at taking over cells and using their second messenger systems to induce translation of abnormal proteins. This enables them to both avoid apoptosis and detection. So they make the cells do funny things. We were just talking about rapamycin. So KSHV is HHV8. It actually relies on the mTOR signaling pathway as seen here. This is the phosphoinositol triphosphate pathway. And it explains, so you can actually use rapamycin for things like skin cancers and certain types of malignancies like Kaposi sarcoma. So there are targets offered by these pathways where we can look at controlling these viral infections. What's interesting is if you look at like the mitogen-associated pathway, a lot of these pathways and the NF-kappa B, a lot of these pathways come into effect when cells are injured. All right, so they enable the cells to either apoptose, which is, if they're beyond sort of repair, but also they help the cells to regenerate, proliferate, etc. The problem is that if they're infected or transfected, this can actually be one of the important steps to actually immortalization of a cell, which is all really cancer is. Okay, at the bottom line. So this is American data. We all know that fella. So the easiest way to avoid any sort of cancer or anything ever is to just say, well, we just don't transplant anybody. But you end up with a situation like you see here, where the number of people on the waiting list is growing and growing and growing. And what's important about dialysis is it's expensive. It's really expensive, like properly expensive. Okay, so even to the state here in this country, dialysis costs about 300,000 Rand per annum per patient. So if you just add up how much that would be if we have about a 6% or even a 1% prevalence of advanced kidney disease, it's a very expensive business. Transplant is a little bit expensive initially and then becomes much cheaper as you go along. So we need to do something. And in actual fact, in South Africa, if you look at our number of transplants, it's only about 20% of the very limited number of people that we actually sort out. So if this is from 2020, the renal registry data. So if you look at the treatment rate of what's called kidney replacement therapy, so this is dialysis, transplant, whatever. Okay, it looks fantastic in the private sector, 729 per million population. That's sort of Europe, kind of Europe type replacement. But if you happen to be a public patient, 44 per million. That puts us down with Uzbekistan, Bangladesh, places like that, you know, so not really consistent with our GDP. So can we push things a little bit? And this is really the sort of part of the talk, I guess. So the improving global outcomes, this is the KDIGO, it's kind of our guideline that tells us what we can and can't do. It's a little nebulous, to be honest, but anyway, it's true. So it says, well, donor candidates with active malignancy should be excluded from donation. I think that's probably reasonable. Would you want a kidney from somebody who has lung cancer? You can try. Okay. What we don't want is this situation. All right. This is a CT scan taken. So a donor a few years ago, if you understand how it works, you retrieve the organs, then they go to the back table. And the back table is where the unnecessary parts are removed, like the gallbladder or the perinephric fat, etc. The organs are sort of neatened up nicely. You check them, turn them over, have a look before you put them in the patient. And then often some of those bits and pieces are sent for histology. So this was a donor, basically 4 organs, 2 kidneys, 1 heart, 1 liver. A few days later, pathologist phoned to say, the back table on the gallbladder showed melanoma. So, anyway, the heart patient said, well, actually recurrence of melanoma in cardiac transplants only been reported in 1 case. The 2 kidneys were removed. One was a child. It was a bit unfortunate, but you know, you have to. And then this poor fella already had received, or basically had received an organ because of a non-benign lesion already in his liver, and he elected to stay with the organ so he could have some time with his family. This is the degree of melanoma on biopsy proven throughout the liver within 8 weeks. Survival was approximately 12 weeks. Okay, so this is what you don't want, right? You don't want this. Okay. So what we've done is assigned categories of risk to donor. Okay, so there's going to be people who are family members who say, well, I had a skin cancer 10 years ago. Is that a problem? I had a thyroid cancer, 10 years ago. Is that a problem, etc.? So we've assigned risk. And I've made it sort of, so minimal risk, so that's deemed sort of about 0.1% transmission. So non-melanoma skin cancers, squamous, be a little bit careful. Non-invasive carcinoma of the bladder. Small thyroid cancers, actually, thyroid cancer doesn't seem to be that bad. And small renal cell carcinoma. So we'll actually consider taking organs from a patient with a history of renal cell. Low, again, fairly acceptable. You can sort of have a look there. Just to talk about the intermediate risk. This is where we start to get a bit nervous. So breast and colon cancer in situ, you need to have a discussion with the patient. Resected, well-differentiated renal cells, so 4 to 7, non-CNS, non-treated CNS, or treated non-CNS malignancy. And it makes sense because a lot of our donors have had brain death. And sometimes it'll be from a bleed from a CNS malignancy. And you'll get a question at 2 o'clock in the morning, can you use this? What you absolutely won't touch, all right, is melanoma in a donor. I've kind of shown you what can happen. Leukemias or neuroendocrine tumors, breast or colon stage 1 or higher. Any CNS tumor that's needed intervention, any metastatic carcinoma, sarcomas, lung cancer as well, no, large renal cell carcinomas. All right. Then to just talk about, let's suppose, as we said, cancer and renal disease kind of go together, right? When you treat people with chemo, etc., we see a lot of renal dysfunction, and it's progressive. Unfortunately, some of the chemo agents, once the renal failure starts, it just progresses over time. So essentially, you will have recipients who've had a history. As a general rule of thumb, most cancers require a 2 to 5 year time in remission. You need to have imaging evidence that they're not there, whether that's CT scanning, MRI, PET scanning, you'll need to decide. You can transplant somebody who's had melanoma as long as it's localized. So the Clark and Breslow system, you need to make absolutely sure that it's very superficial. So you speak to your friendly dermatologist, they're great. You ask them, we get a lot of people who've had, I had a squamous cancer 5 years ago, I had a basal cell, can I get a transplant? And most times they can. All right, so just to look at that. Unfortunately, the one disease that's not on this table, as you see, is myeloma. And why am I mentioning myeloma? It's because myeloma, I don't know, there's something in the atmosphere, I don't know, or in the soil, in the rivers, but myeloma it's on the rise. I tell you, everywhere saying, wow, there's a lot of myeloma. Right? And myeloma and kidney disease are absolutely linked. So you see more and more patients that you do the paraprotein, and there it is. And you go, oh, now what? Okay. And myeloma patients are interesting. They're not like normal cancer patients. They just go along. You give them a bit of chemo here and there, and they just keep going. It's now fairly understood that myeloma, to be honest, is not really curable. Okay, and it's because the plasma cell is tough to kill. It really is. So the question always comes, okay, we've done the bone marrow transplant, we've given the chemo, the patient's in remission, can they get a kidney transplant now because they're in kidney failure? Sure. So this is NDT 2022. They've looked at 2 decades worth of follow-up. And again, it's not clear. So certainly in the state, we're a little reticent to take myeloma patients because they really need to be very well controlled, preferably with complete remission. And that, I can tell you, is very hard in myeloma. It's sneaky, it comes back after a year or two. Hello, I'm here. All right. So I mentioned myeloma because it's a big thing. Okay, it's becoming a real issue. All right, and it's hard to know exactly what to do with it. Very interesting. This was a meta-analysis of various studies, and quite a few of these patients died actually from second hematological malignancies, because you give these patients chemo on and on and on and on for years. Okay, it just goes on and on, it doesn't stop. Right, so the jury's a little bit out about that. So in terms of pre-existing malignancies, to summarize, the highest risk of recurrence is amongst symptomatic renal cell cancer, so more than 7 centimeters, probably not a good idea. Most sarcomas, melanocyte or melanoma, invasive bladder cancers, and multiple myeloma. And then it makes sense an increased risk of cancer-related death in transplantation is observed among recipients with a prior history of kidney, prostate, breast, lung, or plasma cells cancers compared to those without a cancer history. So in fairness, when we fill in the form, we should be aware of what the risk is and do our best for the patient and say, look, this is the risk. Okay. All right, so this is applicable somewhat to anybody, I guess, but end-stage kidney disease patients, so they stay on the transplant list. So it takes about 8 years to get a deceased donor organ these days. It's gone up. And you must all be registered, right, to be organ donors. But over the 8 years, these patients, they're like normal people. They have colons and all sorts of things that you need to screen. People are always moaning about for transplant workup how expensive it is. Do you need to see the cardiologist every year? He gives you a fairly good invoice. Then you must go have a G scope and a C scope. That's another fairly good invoice. And eventually, it's so expensive the patient can't afford to eat. All right. So these are some of the screening guidelines. So breast, a mammogram every 2 years, greater than, once they're over 50 years of age. Colon, it's tricky. You can scope them or do an occult blood every 5 to 10 years if they're 50 to 75. The big one in our country is watching for atypical cells on pap smears. All right, we have very high numbers of patients with atypical pap smears in this country, both HIV, especially because of HIV, but HIV positive and negative. We have very high HPV rates because we don't vaccinate, which we should. It's silly. So they need a pap smear age 21 every 3 years, or HPV testing every 5 years. You can do a PCR now up to the age of 65. And if they have had a hysterectomy, no pap is needed. Lung, if the patients have a 30 pack year history, and they're between the ages of 55 and 80, you can consider annual low-dose CT scanning, but actually the Thoracic Society has different ideas. As you know, in the US, people don't recommend PSA screening now. I wonder how many American physicians don't do PSAs. It's such a litigious society, but anyway. So males 55 to 89 can do a PSA. This, of course, changes if you have first-degree relatives, all right, who have these diseases. Look, okay, renal cell cancer, this is also an important one if there's a family history, if they've got acquired cystic disease, their analgesic nephropathy, long-term smoking, or they've been on dialysis for more than 3 years. Bladder, something we never think about. Lots of people have had cyclophosphamide, lupus patients, etc. Nobody ever does urine cytology. You'll get caught out somewhere. Okay, you do get bladder cancer if you're a long-term smoker and analgesic nephropathy patient. Screening post-transplant, so now you get your kidney and now we need to look after you. Not to forget, history and exam is still quite useful. It's amazing if you just examine the patient, take their weight and say, sure, you've lost a bit of weight. Are you trying to lose weight? No, I'm just losing weight. All right, so little things. Examine them for lumps. You'd be surprised how often it gets missed. And very importantly, especially more so perhaps in light-skinned individuals, they need to check their perineum. Okay, that is where the squamous cancers start. Believe it or not, the HPV associated, it's not always cervical, but you need to have a look or get a friend table. I don't know. Okay. But it's an important area that gets missed. Okay, so patients who have abnormal pap smears need to have the perineal area actually checked. Okay, because it gets missed. So KDIGO in its usual, rather nebulous way to say, says you must develop an individualized screening plan for each transplant that takes into account the patient's past medical and family history, their tobacco use, their competing risks for death. I love that. So if they're going to die anyway, why bother? And how the method actually performs. What's its sensitivity and specificity? Screening for the following cancers per local guidelines. Women, I've just highlighted cervical in red. it's annual in women post-transplant. They must be reminded to do their pap smears. Breast and colon cancer, men, breast and colon cancer. Interestingly, lung cancer screening post-transplant is not recommended by the American Thoracic Society. All right. And interestingly as well, screening for renal cell and urological cancers is also not recommended, although the incidence, as I've shown you, is increased up to 20-fold. We've certainly had a few patients with renal cell cancer, so beware the patient who's got cysts in their kidney. We're not talking about polycystic kidney disease, we're talking about acquired cysts. Okay. So, to prevent global warming, not so bad. It's warmer. All right. So to prevent cancer. So the commoner in lighter skinned individuals, the commonest skin cancer is squamous cell cancer, all right, of the skin. Right? It's really a big problem. And you think patients are told, wear sunblock. It's as simple as that. Or wear a hat. Please, if you're going to go play golf for 5 hours, just have long sleeves, or you can buy those sleevey things you put on. So patients need to be told about sun protection. Okay, even patients who are non-Caucasian, whose skins are still lightish, they will get cancers. They start off, you see them with millions of keratoses, and so on, away we go. So vaccines, we just talk a little bit about vaccines. It's important to vaccinate patients pre-transplant. It's better. You should make sure your vaccines are up to date. And mainly that's because you want to prevent opportunistic infections. But there are some vaccines that are important. What is important to remember, though, is that post-transplant, giving someone live vaccines is very daring because you tend to get the disease. So yellow fever vaccine, ooh, no, don't do that. Okay, so hepatitis B vaccine is very important for dialysis patients and also patients who are going to get liver transplants. Right? They need to be protected. And to just talk about, again, HPV vaccine, Gardasil. So seroconversion with this vaccine after transplant is still around 50 to 70%. And really unvaccinated transplant recipients should get the HPV vaccine, and they should have catch-up vaccinations to men and women between 11 and 26 years of age who've not been vaccinated previously. One of the questions we keep asking our colleagues, and I'm pleased to see that the South African guidelines around this are being updated, is what about vaccinating women after LETS or colposcopy? So once you've had an abnormality. And this is a very interesting little snippet here. So not tested in transplant patients, but in the general population, up to 15% of women with vulvar cancer and 30% of women with vaginal cancer had a prior high-grade lesion or cervical cancer. So it suggests that once you've got HPV, you cannot control it. You need the vaccine. All right? And interestingly, these vulval cancers tend to occur like 5 years later. So we have seen a couple of these, and again, very, very unpleasant, very difficult to deal with. Okay, so I would urge our government, everybody, if you see patients, vaccinate them. It's as simple as that. All right, Trima, I'm not an oncologist, but the basic principles are that you often need to lessen and or stop the immunosuppression. So you need to sit down with the patient and say, look, I'm sorry, we're going to have to bomb your kidney. Now, to be honest, I've never had a transplant patient, really, maybe one ever, that said, I wish I'd never been transplanted. If you think about what it's like to have to do like peritoneal dialysis, so 4 times a day, 365 days a year, you've got to take 20 minutes, scrub your hands, connect the bag, drain it in, drain it out, not make a mistake because you get bacterial peritonitis. Those patients are desperate to just get off dialysis. They don't want to go back, so they'll fight you. Right? They'll say, well, it's so bad, give me some chemo, we'll see how we go. All right. Unfortunately, okay. It is possible to transition the patient from calcineurin inhibitors to drugs like rapamycin, especially for skin cancers. The problem with the mTOR inhibitors is that below GFRs of 40, they tend to cause fairly rapid progression of renal dysfunction. Importantly, if you see a patient who starts to get lots of keratoses, we still have patients on azathioprine. Its metabolite is mercaptopurine. It really is the ultimate drug for skin cancer. It really gives you, on azathioprine, you're going to get skin cancer. It's just a matter of time. Okay, so if possible, try and switch them out. And it's incredible to watch these patients who can't tolerate light-skinned individuals, who can't tolerate MMF. You put them on azathioprine and they start phoning you after about 2 years saying, I've got all these little brown things all over my body now. What's going on? Here we go. All right. Modern chemotherapy, it's getting better and better. There are more side effects. And one of the things that's really changing is immunotherapy. We've had some patients on immunotherapy. I must say, if you're going to give a patient immunotherapy, even if their renal function looks good, you tell them it's going to take your kidney. All right. When it activates the T cells, so unfortunately you have often what's called Hobson's choice. All right. There's just nothing you can do. There we go, short and sweet. So conclusions, in South Africa, transplant is very much linked to the provision of dialysis slots. We need to transplant patients. We need to push things a little bit. So we are getting offers of patients who've found to have a lump in their liver or their kidney. Can they use them, etc., etc. So these are decisions. So it's on the rise, and we will encounter this as an issue in donors and recipients, as well as, frankly, in causing more CKD. We're likely to keep pushing the limits, certainly I do. And we need our colleagues not to shy away from offering organs. We need to. And down the bottom there, you see there, carte blanche first. Anyone know about that? It's called LifePod. So this is a group of Tygerberg medical students, not Wits medical students, who've actually been involved in getting set up, etc., a separate transplant donor ICU at Tygerberg. So the problem with trying to get organs is the donors are a pain. Okay, I'm sorry to say, they're what's the term, you guys? Unalive. Okay, they're no longer technically alive. So to try and convince intensivists and surgeons, etc., that you must keep this patient in the bed and you must use inotropes, you must do everything you can to make the numbers good so we can use the organs. They're like, yeah, but I mean, who's supposed to do that? All right, so this is a very interesting idea. I don't watch carte blanche because it's always very depressing, and as you know, every time very sad stories. But this was quite cool. All right, I thought this was really good. So just to say, transplant, absolutely it has risks. As I told you, the patients will tell you, okay, I went through hell, but I'm very grateful. It's an amazing organ replacement. It really is. And yeah, thank you very much for listening.